diet of the older person needs to meet their individual nutritional requirements and also balance blood glucose levels to prevent short-term symptomatic hyperglycemia and dangerous hypoglycemia. We regularly see older people where their nutritional status may have already been adversely influenced by delayed diagnosis of diabetes.
So why is this?
Simply because the symptoms of diabetes, such as tiredness, passing urine at night, can be mistaken for the effects of increasing age. Similar effects on nutritional status are also seen with a deterioration in other comorbidities, such as an escalation of congestive heart failure, chronic airway disease, which requires steroid treatment, and significant declining mobilities. These can all lead to regular periods of poor control. It is essential to use simple diet history prompts or visual aids to ascertain that staple starchy carbohydrates feature at all meals in those who are managed by diabetes medications, which are capable of inducing hypoglycemia. Need to check that both the older person and their carers know if bedtime carbohydrate snacks are essential to reduce the risk of dangerous nocturnal hypoglycemia. Social isolation and depression, as well as ill health, are often responsible for the adoption of the classic soup and bread syndrome.
There are two issues here. The foods can be quickly digested, causing a peak in blood glucose, but then they may not maintain the blood glucose level until the next meal, so increasing the risk of hypoglycemia. And of course, these types of foods are also inadequate in terms of nutritional balance.
Even in the obese, the diet can still be grossly inadequate, which increases low mood, reduces mobility, and leads to general poor health that impacts on diabetes control.
I've noticed that some older people come unnecessarily avoiding fruit and over-restricting bread and potato portions.
Yes, this is really sad. I have to look for excessive food avoidance because they're often avoiding these foods because they're worried about their blood sugar control. The important message is medicate, not restrict in the frail elderly. Practically, it's important to provide clear written pictorial information showing the required carbohydrate sources at each meal if there's any risk of hypoglycemia. We offer practical shopping and menu ideas in order to achieve adequate fruit and vegetable targets. Only a minority will need to be considered for vitamin, energy or protein supplements. We need to ensure that all involved with care understand the timings of diabetes medications in relation to meals, often discussing with pharmacy if the clients are using a medicine management box.
Yes, I can see this is important because some diabetes medications are more effective and better tolerated if taken at the correct time in relation to meals.
And if there are concerns about meal timing or meal admissions, then often we would advise modified release products should be considered. Most elderly people, unless very obese, require 30 to 50 grams of carbohydrate per meal, equivalent to about 2 or 3 slices of bread. The plate models we have demonstrate these portions really well.
This plate model shows how there's an inadequate amount of carbohydrate at this meal.
We use every meeting to motivate and reinforce realistic targets for diabetes control and, if appropriate, weight gain or loss. Summing up, dietary and diabetes targets need to be tailored to the individual, both their presentation and their risks. Emphasis is always on practical food choices. In all consultations, we respect long-standing dietary choices, but remember that the majority of elderly people are very open to change if the positive benefits are understood and have been presented clearly.
An annual diabetic foot review is of great importance for diabetic patients due to the increased prevalence of diabetic foot complications in older people. If diabetic complications, for example compromised circulation or neuropathy, is detected early, it's possible to reduce the impact this may have on a person's quality of life by preventing or reducing the risk of ulceration. This in turn can lead to a reduction in hospital admissions and possibly prevent unnecessary amputation in extreme cases. The aim of an annual diabetic foot review is to examine the patient's feet and aid early detection of risk factors of ulceration. Patients should be classified into one of 4 categories: low risk, at increased risk, high risk, or active foot disease as per slide. The low risk category is when a patient scores 5 out of 5 on sensory perception to a 10 gram monofilament, dorsalis pedis and posterior tibial pulses are palpable, and there is no deformity or asymptomatic deformity of the feet. The at increased risk category is when there is less than 5 scored on the 10 gram monofilament test, either one or both of the pulses aren't palpable, or if there is symptomatic deformity of the feet, for example clawed toes with associated callus. The high risk category is when there is an at increased risk foot with a history of previous ulceration due to neuropathy or peripheral vascular disease, areas of increased pressure points indicated by callus or corns, or symptomatic deformity of the feet. Active foot disease would include active foot ulceration or wounds, infection or cellulitis, or acute Charcot joint inflammation. NICE guidelines indicate that foot assessments should include testing of foot sensation using 10 gram monofilament or vibration, palpation of foot pulses, and inspection of any foot deformity and footwear. Vascular assessment should include palpation of the dorsalis pedis and posterior tibial arteries in the foot. The dorsalis pedis artery is a continuation of the anterior tibial artery and is palpable over the dorsal aspect of the cuneiform bones before disappearing into the first and second intermetatarsal space. The posterior tibial artery is a continuation of the popliteal artery and can be palpated behind the medial malleolus. It can lie quite deep, so firm pressure may need to be applied. The posterior tibial artery can be difficult to palpate in the presence of edema. If pulses aren't initially palpable by hand, a Doppler ultrasound machine can be used to locate the pulses. Sensory testing of the feet should be carried out using a 10 gram monofilament to test 5 areas of the forefoot, as indicated in the slide, for sensation. To do this, you must hold the monofilament perpendicular to the foot. Apply pressure onto the filament until it bends and hold for approximately 2 seconds. Take care not to tickle the foot with the monofilament, as it will be testing a different sensation, thus giving inaccurate results. Alternate the order of testing sites so that patients lose the ability to guess. Assume neuropathy if there is a score of less than 5 out of 5. Vibration sensation can be tested at the bony prominences, for example the outer borders of the 1st and 5th metatarsophalangeal joints and the ankle joint. Assessing the feet for deformity can indicate potential areas of breakdown or ulceration. Check for deformity such as bunions, clawed or mallet toes, prominent metatarsal heads, lesions such as corns, callus, blisters or ulceration. Check for history of ulceration, amputation and signs of current infection, cellulitis or gangrene. Good fitting footwear can prevent diabetic foot complications which may arise from irritation or abrasions from the upper of a shoe. A good fitting shoe will also support the joints and bones within the foot, thus limiting joint damage which may go undetected due to neuropathy. Check for adequate size, depth and fit, ensuring no irritation or abrasions on the feet from footwear. It is important that all diabetic patients should have diabetic foot care education and footwear advice supported by a leaflet. Low risk category patients will require an annual review with their GP and self-care. A podiatry referral isn't necessary. At risk category patients will require a referral to the podiatry service for regular checkups and palliative care to prevent further foot complications. High-risk category patients will require a referral to the podiatry service for regular checkups and treatment as necessary. Self-monitoring can be carried out, but no self-treatment due to the risk of injury leading to further complications. For active foot disease, such as cellulitic infections or gangrene, a referral should be made immediately to the specialist diabetic foot team.